Thank you for that wonderful introduction, and thank you, Northwell Health, for this invitation. I'm honored to be here with you today. I had the good fortune to found and lead a company that I built into a significant global brand. I always had a deep interest in the health and well-being of my workforce, 85% of which was women, who were at the heart of my company, both as customers and as employees. My role led me to think a lot about the economic impact of women on the workforce and to see that impact firsthand. Because of my interest in the health of my workforce, I quickly learned about the disparities in women's health research, and I was quite dumbfounded. I kept wondering, how is it possible that scientific research and investment could be so insignificant for half of the population? So let's frame this dialogue with some data. Women are 52% of the population, nearly 51% of the workforce, control over 60% of the personal wealth in the US, are responsible for over 85% of consumer spending, and make over 80% of healthcare decisions for their families. And let me point out that over 60% of employees entering the healthcare industry are women, and 75% of Northwell's employees are women. And when women are pulled from the workforce because of inadequate treatment options or to care for their families, there are direct consequences for our businesses and our economy. Yet women have been historically left out of medical research, even for diseases that differentially, exclusively, predominantly, or disproportionately impact them. As a business leader, I tend to look at problems with economics in mind, and I believed that the solution to these disparities was hidden in the economics behind them. I don't need to tell you that change starts with data, and the quality of that data greatly affects the outcomes that are offered. But for years, we lacked evidence. We lacked data about the economic costs, the benefits, and the social impacts of attention to sex and gender in health research. And no one had evaluated the costs we incur and the benefits we leave on the table when research includes women. In 2019, we created WHAM, Women's Health Access Matters, a 501c3 to catalyze accelerated research and investment and focus on creating the WHAM report to build the business case for funding research by asking, what are the economic impacts of increasing investment in women's health research? And we commissioned the RAND Corporation to begin a rigorous focus study to quantify those costs and benefits of increased research on diseases which disproportionately, exclusively, or differentially affected women, and which had not been widely studied. We chose 4 areas to study: brain health, heart health, autoimmune, immune disease, and cancer. Male and female bodies are different, and those differences go way beyond our reproductive organs and down to the cellular level. Just consider a few examples of how those differences manifest in health outcomes. Women are 2/3 of all patients with Alzheimer's disease and are twice as likely to develop Alzheimer's as men. Heart disease is the #1 killer of women, and women are 50% more likely to die within the year following a heart attack than men. Lung cancer is the #1 cancer cause of death in women, and non-smoking women are twice as likely to develop lung cancer as non-smoking men. Lung cancer kills more women than breast, ovarian, and cervical cancer combined. In each of these examples, we still don't know why women are affected disproportionately, as there isn't enough data and research, and it isn't because we live longer. So now let's take a look at the funding on women from NIH, the largest funder of research. 15% of the NIH budget is allocated to studying women and lung cancer, even though it is the #1 cause of cancer death in women. 12% of the NIH budget is allocated to studying women and Alzheimer's disease, yet 2/3 of the population who have Alzheimer's disease are women, and women are twice as likely to have Alzheimer's as men. 7% of the NIH budget is allocated to studying rheumatoid arthritis, even though it afflicts 70% women and is debilitating at a much earlier age. And only 4.5% of the NIH budget is allocated to studying women and coronary artery disease, even though heart disease is the #1 cause of death in women. 1 in 3 women will die from heart disease. As business people, I doubt any of us would find these percent allocations, 15, 12, 7, 4, acceptable for 52% of our population. However, here's some good news. It turns out that women's health research isn't just good science, it's a good investment, and it yields far higher rates of return than general research. In fact, the WHAM report finds a higher rate of return for women's research across our initial disease areas, cardiovascular disease, autoimmune, Alzheimer's, and cancer, driving billions of dollars to the economy through greater quality of life, workforce and economic gains, and reduced healthcare costs. The WHAM report finds investing $350 million across the 4 diseases we studied would in fact generate $14 billion in economic returns. Based on these microsimulation models and this data, a resolution was presented in Congress by Senators Tammy Duckworth and Jan Schakowsky to increase funding for women's research. This past June, WHAM hosted a celebration in DC for the 30th anniversary of the Revitalization Act of 1993, which established guidelines for women to participate in research and clinical trials. We honored several of the original leaders who helped pass this act, Barbara Mikulski, Connie Morella, Dr. Vivian Pinn, and we were delighted to be joined in person by retired Speaker of the House, Nancy Pelosi, who presented vividly her thoughts and ideas on women's health. And then we were very appreciative of the participation of members of the Appropriations Committee and others from Congress from both sides of the aisle who joined us virtually. That afternoon, we brought together many thought leaders from different parts of the ecosystem to participate in developing a strategy to create innovation and a more urgent approach in shifting the playing field as it exists today. We created 3, not 30. What can we change in the next 3 years and not wait another 30? This prestigious group of leaders signed on to 3 significant goals. First, double the NIH budget, that segment that reflects the 4 disease areas we studied, focusing on areas which research is underfunded. Double the amount of investment for VCs and other sources of funding from 2% to 4%, channeling more resources into female-specific research, unlocking the substantial untapped growth opportunities in diagnostic treatments and prevention for women's health. Yes, it's hard to believe, but only 2% of VC money is raised by companies run by women. Improve diversity and access to clinical trials. We must commit to increasing diversity and equity in clinical trials by increasing the number of Black, Latina, and other underrepresented women participating in the clinical trials from 3% to 6%. We want to support access to clinical trials and break down barriers, thereby enabling more enrollment of women. The third goal is to mine the data and create a WHAM accountability index and identify through all means those who meet and those who do not meet the criteria set by NIH to report analyses by sex. How will we ever have precision medicine for men and women if we are not studying both sexes equally? Data is key to WHAM, and not only will we continue to drive to have more data on women, but we will also strive for the inclusion of all race and ethnicity, and be sure that we are reflecting the basic differences of sex as a biological variable. Let's go back to the discussion of AI, as we hope it can play a significant role in accelerating funding for women's health research in several ways. While it is true that there may be certain limitations in terms of data research on women's health, I am very optimistic that it can still provide valuable guidance based on the existing knowledge and studies that we do have. How? Well, AI can exist in analyzing existing data on women's health to identify gaps and disparities. That would increase funding. Its algorithms can prioritize research topics related to women's health by analyzing health data, identifying patterns that we might not see, and predicting potential areas of concern or interest. And AI can also contribute to the development of personalized medicine by analyzing data on individual patients by considering factors such as gender, age, ethnicity, and can help identify specific health concerns and improve treatment options tailored specifically to those patients. While it is true that there may be certain limitations in terms of data and research, I am optimistic that it will still provide valuable guidance based on the existing knowledge that we have. We can't improve healthcare or access to healthcare without including women in research. In order to keep up with the innovation that is happening, and it's happening rapidly, then investing in research on women's health is a mandate, which can shift healthcare outcomes, reduce economic burden, promote gender equality, and create economic opportunities. It is truly a strategic investment and commitment that creates more productive and healthier societies. Let's find ways to collaborate on this journey in 3, not 30. And thank you for the opportunity to share these ideas here with you today.